Zach, we've been doing this for a long time, right?
Yeah.
Since 2021-ish.
Yeah. Coming up 4 or 5 years.
Yeah. And then part of this is we've been doing a series on non-conventional ventilation.
We like to think that we are the Vent Settings podcast.
We are. Can I tell you when I first heard about percussive ventilation as a mode?
Was it when you were preparing for your pediatric critical care boards?
No, it was when I was interviewing for my current faculty position with my chief.
Oh, that's scary. Did you just tell me you knew everything about it already?
No, I said, what's VDR? So I don't want that to happen to our listeners.
Well, yeah. Shall we share all the fun information we learned from Dr. Lynn?
Yeah, let's do it.
Welcome back to PedsCrit. I'm Zach Hodges, a pediatric intensivist from the University of Texas Southwestern in Dallas.
And I'm Alice Shanklin, a pediatric intensivist at Cohen Children's Medical Center in New York. And today, we're coming in for part 2 of our high-frequency percussive ventilation episode, otherwise known as volume diffusive respiration, or the VDR.
Yes, and to do that, we are talking with Dr. John Lynn. Dr. Lynn is the Critical Care Fellowship Program Director and the Medical Director of Respiratory Care at St. Louis Children's Hospital. He pioneered percussive ventilation for their group just over 5 years ago, and we are so excited to be talking to him today about this.
Yes, let's get right to the content. Let's get your starting settings. So to bring it back to our patient, we have an 18-month-old with ARDS secondary to RSV bronchiolitis. Let's say that she's on maybe SIMV pressure control, PEEP of 14, pressure control of 18, so 32 over 14. The rate is 28, the FiO2 is maybe 60%. Where are you starting those settings? What variables are you needing to select and talk with the respiratory therapist about, and what are your starting settings?
Sure. Before answering the specifics, it's worthwhile to review how the VDR functions, like how the mechanics of the VDR actually work. So all the VDR settings are related to either gas flow rate or time. So as long as you have a high pressure gas source, actually the VDR works with or without electricity. The only reason you need electricity is to run the sensors and the software and the lights that show you what the pressures are on the monitor that's built into the device. So you could unplug the machine and you won't hear any difference at all to how it's delivering respiratory support to your patient.
That's reassuring or not.
This is our apocalypse ventilator for sure.
Well, I would not advocate this ventilator as a disaster management strategy because it needs a high pressure gas source. In addition to not having electricity, hospitals that are, flooded may not have high pressure gas source.
You're so right. You're so right.
Sorry to get you off track as you were.
Because it's a flow and a time based, those are the only two variables that you control. All the knobs, there's like a dozen knobs on the front of this machine.
Yeah, there are.
All they do is influence some aspect of those two variables. And the patient's underlying pulmonary mechanics then define the subsequent measured pressures that result from that gas flow over whatever amount of time was spent. For two patients then who have different compliance, the exact same VDR flow rate and time settings will result in different measured pressures because that pressure is the dependent variable based on what the patient's lungs are doing, not what the ventilator is doing. So set the inspiratory and the expiratory time in seconds for either the convective rate that's delineated with a capital I, capital E, I to E ratio, or their percussive frequency, which is designated by a lowercase I and a lowercase e on the screen. With this background in mind, we can then talk about VDR settings and how they correlate or not with conventional settings. So on the VDR, the convective rate refers to the respiratory rate of the pressure control component of the VDR. So if you want to have a convective rate of 15 breaths per minute, the total respiratory cycle is 4 seconds long. And you set the inspiratory time and the expiratory time. So if you want a convective rate of 15 with an I to E ratio of 1:1, then you set the I time at 2 seconds and the E time at 2 seconds to give a total respiratory length of 4 seconds, which gives you 15 breaths a minute. The percussive rate then describes the high-frequency percussions, and that's in the lowercase I to E ratio that's delineated by the lowercase I and the lowercase e. And we always just keep this I to E ratio 1:1. I don't have a good feel for what would happen if you change that I to E ratio. So sometimes on the oscillator, I'll go from 33% inspiratory time, which is the typical default starting setting, and increase it up to 50% if I'm trying to really just eke out the last little bit of oxygenation support from the oscillator before the surgeons are content to come and cannulate the patient for me. But for the VDR, I just keep that percussive IDE ratio at 1:1. The other thing about the percussive rate is that the units are beats per minute rather than cycles per second, which is hertz as a unit. So a percussive frequency of 600 beats per minute is the same as a frequency of 10 hertz. So those are the time-based settings. So IDE ratio, convective inspiratory time, convective expiratory time. You add the two together, take 60 divided by what you get, and that's the breaths per minute. The settings that are related to flow are then divided into flow that occurs during inspiration and the flow during expiration during the convective breaths. During the inspiratory phase of the convective rate, that's set with what's called the pulsatile flow rate, and that generates an average inspiratory pressure over the duration of the inspiratory time. So that's different than the maximal inspiratory pressure that the VDR monitor also reports out. That maximal inspiratory pressure is what the pressure is at the end of the endotracheal tube, not what is at the alveoli. And the assumption is that the pressure that the alveoli is seeing at the peak of that percussive beat is meaningfully less than that measured maximal inspiratory pressure. So the average inspiratory pressure, then you have above that the maximal inspiratory pressure. Those are set by pulsatile flow rate. So the AIP then correlates with what would be considered the peak inspiratory pressure in conventional modes of ventilation, so the PIP. So you can think of the AIP in similar ways as you think of the PIP. During the expiratory phase of the convective rate, two flows generate an average expiratory pressure. The first is demand flow. So that is a non-fluctuating, continuous delivery of gas flow from your source of some percentage of oxygen. Then on top of that, you add the oscillatory flow, and the oscillatory flow provides percussive beats during the expiratory phase. So high-frequency percussive ventilation has percussive beats both in the inspiratory phase and the expiratory phase. The average expiratory pressure you can think of similarly to your positive end expiratory pressure, or your PEEP. What can create confusion is that the labeling on the machine labels the knobs that adjust demand and oscillatory flow as demand and oscillatory PEEP. But it's important to remember that that knob is changing flow, and the patient's mechanics are what defines what the PEEP is. So again, the demand flow provides a constant flow, and that's there in case the patient is spontaneously breathing. So if the patient is spontaneously breathing and their inspiratory flow, their peak inspiratory flow of the patient's breath exceeds the flow that occurs during the expiratory phase of the VDR, that patient can entrain ambient air at 21% oxygen. And so one of the purposes of the demand flow is to provide at least some amount of constant flow that allows the patient to receive oxygenated gas that you think you've set when you've set the FiO2 on this ventilator. So the AEP, or the average expiratory pressure, is equivalent sort of to the positive end expiratory pressure in conventional mode. The average inspiratory pressure is equivalent to the PIP on conventional mode. The other thing to keep in mind then is because the VDR is really only adjusting flow and time, as a result of how this is delivered, the measured pressures, again, reflect the patient's pulmonary mechanics. So as the patient's lung disease resolves and their compliance improves, with no change in the ventilator, the measured AIP will decrease. And that's how you know the patient is getting better. So on a conventional vent, if you set in pressure control and the respiratory therapist goes to do a vent check, or somebody's just looking at the ventilator and the PIP has somehow changed below what you thought it was, somebody's going to turn the knobs to make the PIP back to what you said you wanted. But you don't do that with the VDR. So you want that pressure to begin to fall because it means that the patient's lungs are improving. The other piece about the VDR is that a change in any setting on the VDR will have changes to all of the other measured parameters. So nobody other than a respiratory therapist who's trained on how to use this machine should touch anything, including the FiO2. So that is like, for pragmatic purposes, like we change vent knobs a lot. But on the VDR, don't do that unless you're the respiratory therapist.
Yes.
Wise words.
So getting back to the vignette then. So this patient who's currently supported in pressure control mode with a pressure control of 18 over a PEEP of 14, which gives the PIP of 32, a rate of 28, and an FiO2 of 0.6, I would start with the following settings. So the pulsatile flow rate in order to achieve the average inspiratory pressure. Because the VDR does provide enhanced ventilation, I usually set the AIP a couple points lower than whatever the PIP was in conventional, somewhere between 3 to 5 points lower. So for this patient, I'd set the pulsatile flow rate and titrate it until the AIP is reading 28-ish, somewhere in there. The average expiratory pressure, which is the equivalent of the PEEP, I would target to be the same as the conventional PEEP. So in this patient, 14. The way I set the demand versus the oscillatory PEEP or flow, which is what you add together to create the average expiratory pressure, is I tend to just cut it in half. So for this patient who I'm targeting an AEP of 14, I would set the demand flow to achieve a pressure contribution of 7, and then the pulsatile flow to achieve a contribution of 7. That's something that I've started doing, but that's not how we first started using it. So the manufacturer just recommends that you try to shoot for an AEP by using a demand flow that gives you a pressure of somewhere between 2 to 5, regardless of what your target AEP is. I can't say that I have any evidence that one way is better than the other, but typically if my PEEP is super, super high, like into the high teens to 20s, then that's typically in a much bigger patient who then has a much higher peak inspiratory flow when they have a spontaneous breath. And if I'm trying to maximize their oxygen support, then I don't really want them in training room air, ambient air, when they take a spontaneous breath. And so that's the rationale for why I do what I do for the demand and the oscillatory PEEP to set the average expiratory pressure. So that deals with the pressures. Zach, it looks like you have a question.
I think your organization here is exceptional, and that's the only way that we're going to be able to communicate this clearly. Let me see if I can read back some of the highlights of the core components here and make sure that I have it.
Okay.
So on the VDR, we're setting time and we're setting flow and we're measuring pressure.
Correct.
So with that, you've mentioned the average inspiratory pressure. That is going to be the closest thing that's analogous to our peak inspiratory pressure on the conventional ventilator.
Correct.
And the average expiratory pressure, which is closely analogous to the PEEP on conventional. And it seems like when you're setting this ventilator up for the first time, you are manipulating time and flow to get targets of your average inspiratory pressure and targets of your average expiratory pressure. But ideally, after you make these initial settings, you're going to then watch these pressures to give you insight into the trajectory of the patient.
Yes. And then obviously what their gas exchange is doing.
Yeah.
That first 5 to 10 minutes of putting the patient on the VDR is like everybody's got to be there. This is not just set it and then I'm going to walk out the room. You need to make sure that the patient is doing okay, that their SATs are okay, that a reflection of their ventilation status, and we do that with transcutaneous monitoring because you can't monitor end-tidal CO2 with this. And then once you've reached stability and you're content with, the patient is actually exhaling sufficiently, so not becoming overdistended, you've dealt with the typically huge amount of secretions that you get out when you first put the patient on, then you just sit on your hands and you watch. And when you see the pressures fall, you should breathe a sigh of relief. It's like, hey, the patient's better. You shouldn't then go chasing it to try and make it be what it is that you had originally targeted.
And so in the room,
Yeah.
You're walking up to this green thing covered in knobs. You see uppercase I, uppercase E. You then use that to calculate your respiratory rate.
Right.
And then you see your AEP and your AIP. And the AEP is your kind of convective PEEP, and your
Right.
AIP is kind of your convective PIP.
Correct.
What are you looking at in terms of the percussive rate?
Before I get into that, then how do I set the convective rate? Right. So the patient in this vignette had a rate of 28, and the convective rate, and then the I to E, the capital I, capital E. We just start with basically age-based norms. So For patients less than a year, we target a typical convective rate of 30 breaths per minute. Patients between 1 and 4 would typically have a convective rate of 20, which gives a total respiratory cycle of 3 seconds. And then school age and teenagers, then convective rate closer to 15, which is a total respiratory cycle of 4. So then it's like 2, 3, 4 seconds in those ages for the total respiratory cycle length. And then we preserve on 1-to-1 I to E. Then for the person that we're trying to get a convective rate of 30, then it's 1 second, 1 second for inspiratory, expiratory time. For the person that we're trying to get a rate of 20, then it's 1.5 second, 1.5 second. The person we're trying to get a rate of 15, then it's 2 seconds, 2 seconds for the inspiratory time, expiratory time. So for this kid who's 18 months old, I would try and target a convective rate of 20. So the I time would be set at 1.5 seconds and the E time would be set at 1.5 seconds as well. For the percussive frequency, so that's also set typically based on age with a range of 400 to 700 beats per minute. And younger patients have a higher starting percussive frequency because their time constants are shorter, and older patients have a lower starting percussive frequency. And I don't ever start at the edges. I always start more in the middle, and then it gives me room to adjust. So for this 18-month-old, I would start a percussive frequency of somewhere around 550 to 600 beats per minute. And then in terms of setting the oxygen, every time I transition to the VDR, I always start at 100% oxygen, unless there's some reason that I don't want to use 100, that it would be harmful to use 100% for a brief period of time. And the goal would be to then get closer to 60% or less over the next hour or so, once you've made sure that the patient is tolerating this. So this patient probably would be fine starting at an FiO2 of 0.6, because that's the FiO2 they've been on conventional. But in making this transition, I think it's helpful to just overshoot, because this is not a patient who has underlying cyanotic heart disease, who should have lower sats, and you're worried about pulmonary overcirculation if you use too much oxygen, et cetera, et cetera. So that was a lot of discussion for this patient in pressure control with a PIP of 32, a PEEP of 14, a rate of 28, an FiO2 of 0.6. My starting VDR settings would be an AIP of around 28, an AEP to be the same of 14, a convective rate of 20, achieved with 1.5 seconds for inspiratory time during the convective rate, and 1.5 seconds for expiratory time during the convective rate, then a percussive frequency of around 550 to 600, and an FiO2 of 1.0.
Excellent. This is a beautiful answer to the initial starting settings question. All right. May all of our fellows be so lucky. I wanted to focus in, we need to talk about how we manage the percussive rate. But before that, I wanted to focus in on your I time and your E time for the convective rate. It's really kind of like a T high and a T low if you're used to APRV.
Yeah.
In pressure control ventilation, if I'm stretching out the I time, I expect a higher total tidal volume. Is that the same with if I'm stretching out the I time in VDR? Do you mess with this?
I do. So it's important to keep in mind that every single beat on the percussive frequency during AIP provides a degree of re-recruitment. And you stack them up together, and the longer you keep going, the more potential recruitment and also the more potential overdistension you see. So manipulating the convective I to E ratio is like one of the first things I do when I'm continuing to struggle with CO2 clearance and I don't want to raise the AIP anymore. And so like what you're asking is, how do you manipulate the ventilator once you put it on?
Yeah.
Basically.
Yeah.
And so if the patient is persistently hypercapnic, once you've put the patient on the VDR at these starting settings, the two ways to improve CO2 clearance are either to increase the inspiratory time while keeping the same convective rate. So from this patient's vignette, 1.5 second I time, 1.5 second E time, I might go to 2 seconds for an I time, but then shorten the E time to 1 second, which then preserves the convective rate of 20 breaths a minute because the total cycle length is 3 seconds. What that allows then is that for 2 seconds, the patient is sitting at the average inspiratory pressure with a percussive frequency of, call it 600. And so in that 2 seconds, the patient is getting How many? So let's see. So 600 is a frequency of 10 hertz. So in 2 seconds, they get 20 percussions. And each of those percussions then does move a subphysiologic tidal volume that does participate in gas exchange. And you've then augmented the convective ventilation you're achieving with the percussions while maintaining the same amount of convective ventilation from the pressure control rate. Does that make sense?
Yes.
And then the other way to improve CO2 clearance is then, of course, to just raise the AIP. And you could also change the delta between the AIP and the AEP. And so if you make that delta bigger, then your convective rate with each of the convective breaths, the 20 breaths emitted in this example, then you get a slightly bigger tidal volume moved, physiologic-sized tidal volume with that convective breath, while also maintaining each of the percussive beats and the subphysiologic tidal volume that occurs with each percussion. Now, you can imagine that doing either of those things also increases mean airway pressure. So if you lengthen the I time or you make the AIP higher, then the mean airway pressure improves. So doing those things to improve ventilation will also potentially improve oxygenation if the patient's oxygenation state is mean airway pressure sensitive or responsive to mean increases in mean airway pressure. The most I have made the I to E ratio prolonged is probably 2.5 to 3 to 1. So in the older teenager, where I'm shooting for a cycle length of 4 seconds or a convective rate of 15, then I'll make at most the I time be 3 seconds and the E time be 1 second. And so that's an I to E of 3 to 1. Because again, I need the patient to exhale. The next question then, everybody always then asks, well, what do you do with the percussive frequency? How do you manipulate that? And that's a little trickier because that has to do with the patient's underlying time constant. And whether or not a percent change in respiratory rate results in the same percent change of the delivered subphysiologic tidal volume from that percussive beat. So in this patient, when we went from 1.5 and 1.5 of I to E to 2 to 1 for I to E, then in 2 seconds at a percussive frequency of 600, that patient gets 20 beats, 20 percussions during AIP. If I make that 600 be 650 or 660, let's make the math easy. So I went from 600 frequency to 660 frequency. That's a 10% increase in the percussive frequency. If the subphysiologic tidal volume decreases by less than 10%, which each of those percussions, then I have achieved increased ventilation from the subphysiologic tidal volumes delivered by the percussive frequency, right? So 600 to 660, let's make an arbitrary. Each of the percussions, when it was at a 600 frequency, delivered 10 units of volume. When I went from 600 to 660, if that volume only decreased to 9.5, then I have increased ventilation. And increasing the percussive frequency will improve my ventilation for this patient. If, however, by going from 600 to 660, the unitless measurement of subphysiologic tidal volume went from 10 to 8, then I have worsened ventilation delivered by the subphysiologic volumes moved during the percussion. This is way easier to understand if you write it out.
Yeah, you could do the math. So, but how do we measure for that? Or just looking at the
trial and error.
transcutaneous? Yeah.
Because the trial and error is there's no way for us to measure the volume that's coming in and out with the percussive beats. This is then why we always monitor these patients with continuous transcutaneous CO2 monitoring. Is that gives you an understanding of, are you making big changes? And understanding that it's not always exactly the same as what your PCO2 is, but the direction of change does reflect what is happening with your arterial PCO2 concentration.
So as we think about these changes and whether or not changing your percussive frequency is going to help ventilate the patient, what are your sort of typical ranges for each age group? Sure. And what's too high, what's too low?
So again, the typical maximum minimum range is 400 to 700. Because we're not typically doing this for 6 months or less, then it's really about a year. a year to 2 years in that range, it'll be somewhere between 550 to 600. For the toddler, it'll be somewhere closer to 550, maybe 500. For the teenager, then like 450 to 500, somewhere in there. And again, it's all time constant based, right? And in particular, the expiratory time constant. So just as a review for any residents who are listening to this, time constant is the amount of time it takes for half of the volume to inflate or deflate of the alveolus. We can't, of course, measure the time constant of a single alveolus. So what we're using the time constant for is a reflection of how much time it takes the lung to inflate and deflate. So older people have longer time constants. It takes longer for half of my lung to inflate or deflate than it does a 1-month-old.
What are the harms here if we get this percussive number wrong? Like if I signed out a 2-year-old to you who is on a percussive rate of 300, what would you think about that?
I would wonder a little bit about what the potential harms are from then. So that percussive frequency so a percussive frequency of 300 is then a frequency of 5 hertz. And when you're looking at a frequency of 5 hertz, then the time constant of that small child is short enough that you're now starting to potentially move something that's not quite subphysiologic in terms of the tidal volume. And you will be able to see that the patient's chest is bouncing a lot. And if the patient's chest wall is bouncing that much, then 100% the alveolus is seeing increased stress and strain from each of those percussions, and your risk of air leak increases.
Nice.
So I would worry about that.
Okay, what if I'm signing out a teenager with just a classic ARDS to you and I've got him on a percussive frequency of like 800?
I don't know if actually the machine will work at a percussive frequency of 800, and maybe it does. I just never turned it up that high.
Totally.
But I'll raise my eyebrows. But if you then tell me that the patient's sats are 95% on 40% oxygen and their pH is 732 with a PCO2 of whatever, then fine, great.
You'll be polite. You won't change the plan of care. You're going to be polite about it. You'll think it's weird. You'll be like, that's great. Yeah.
Right. If the patient's doing fine, then what do I care what the percussive frequency is?
Nice. All right, I'll take it.
As long as it's not too low. So it's when the percussive frequency gets low that you run the risk of introducing more shear stress to the alveolus.
And if it's too high, the risk would be it's just not going to be very effective. Is that right?
Well, if the percussive frequency is very high and your convective I to E ratio is also very high, then the relative amount of time that the patient has to exhale will go down, and you potentially run the risk of generating more overdistension.
Nice. And then if someone said to you, based on this conversation, like, yeah, some have them on a percussive frequency of 400, they're a 6-month-old, but they look fine, like they're not like jiggling too much, I don't see any weirdness on my physical exam. Would the number alone still be enough to sort of raise an eyebrow for you?
I would.
Yeah.
It would. Like 400 is still, that's pretty low. We are trying to deliver high frequency. And when you're starting to get that low, then it's no longer really that subphysiologic in terms of the tidal volume that's being delivered.
This has been so helpful. We've learned so much about the fundamentals of setting a VDR and monitoring patients. That time of transitioning from conventional to non-conventional modes of ventilation is always somewhat perilous. Will you tell us what should we expect from our patient as we physically transition them to the VDR?
Sure.
What are the mishaps or pitfalls we need to watch out for?
Of course. So even before we put the patient on the VDR, it's important to have a transcutaneous CO2 monitor placed on the patient, reading and then calibrated with a blood gas. You don't want to put the TCOM on after you've already put the patient on the VDR. You want it to show a number and to be solid green, not that pale green where it's still like trying to equilibrate. This is important because it allows us to monitor whether or not we are way overshooting with our ventilation when we put the patient on the VDR. It's probably not very good to take a patient's PCO2 from 70 to 40 in 5 minutes.
It's a big swing. Yeah.
I don't think the cerebral vasculature likes that very much. So because improvement in ventilation can occur quite rapidly, you really want to have that TCOM monitoring in place and reading already. And then you want to make sure that the gas is humidified. And we achieve this by nebulizing saline continuously into the circuit. And we use a vibrating mesh nebulizer, so the Aerogen. The reason we use that is it tends to cause a little less rain out as opposed to a small volume neb. And I think most places have an Aerogen or some equivalent vibrating mesh nebulizer. And that then is necessary to avoid drying out the conducting airway mucosa, as well as maintaining humidification to keep the secretions as thin as possible to make them easier to suction. One quick caveat about delivering other medications through continuous nebs through the VDR is, so this phasotron, this like weird name device that sounds like it came out of some kid's cartoon, like the Transformers or something. So the phasotron, it's a sliding metal plate. And so if anything creates more friction, it interferes with how well that plate slides. And when that happens, the noise that the thing makes sounds different. So it's pretty loud, this phasotron. And if you walk into a room and you can't hear the VDR, then something's wrong with the device. And the phasotron is not working appropriately. So if you nebulize things like mucomist or DNase or antibiotics, like all of those things, the diluent tends to be in glycerol. And glycerol tends to be sticky. And a device that's supposed to slide with minimal friction, that doesn't go well together. So patient with cystic fibrosis, you're trying to do mucomist and pulmozyme, and you need them on the VDR. Our standard is that for a patient that's not getting any nebulized meds other than saline, we change the phasotron out every 3 days. If we're adding then a nebulized medication, we change that phasotron out every day, if not sooner than that, based on what it looks like the phasotron is doing. I mean, everybody's been in the room when the IPV machine is going. The phasotron sounds as loud as that. And if it doesn't sound as loud as that, then something's wrong. Part of the reason we change it out every 3 days is that saline nebs also crystallize. Crystallized salt on this sliding plate also interferes with the movement of that sliding plate. So that's why we change it out every 3 days also, just as a routine. Then you put the patient on the VDR, you're watching for chest movement. And unlike the oscillator, where traditionally the teaching is you want the bounce to go all the way down to the pelvis, you don't need the bounce to go all the way down to the pelvis in the VDR. You just need to get it down to the end of the rib cage, so the costal margins. You need the chest to be moving. Immediately following initiation of VDR support, then you tend to get a lot of secretions. And so being ready to suction every couple of minutes is really important. And it should be inline suction, and you should have the right depth, so you're not constantly going down into the carina. And really what you're doing is you're just trying to keep the ET tube open. We'll typically then get a blood gas within 1 to 2 hours, and then a repeat chest x-ray about 3 to 4 hours afterwards. So the blood gas is just to then provide like an actual measured amount of ventilation, even though we have the TCOM running. The TCOM is to allow us to follow trends, and then the blood gas is then to actually know what the number is. The chest x-ray is important just to understand whether or not we're running into any problems with overdistension. Oh, which reminds me. So one of the other relative contraindications to VDR is someone who has a pneumothorax that you've not put a tube in.
Oh, yeah.
So, right? So if you have a small apical pneumothorax that's not so big for you to even think that it's worth putting a chest tube in, like that's not a person to put the VDR on, because that small pneumothorax will get bigger and you don't have a chest tube to evacuate it. And that's going to be a problem. If you have a patient who has a BP fistula and there's a chest tube in place, and the chest x-ray has a relatively inflated lung, there have been some case series of very successful management with the VDR on a patient who has a BP fistula with a continuous air leak that allows slightly lower AIP than comparison to PIP while you're maintaining ventilation. I don't know that that's necessarily any better than just tolerating a little bit more hypercarbia in conventional. I would worry a little bit about what's happening during the peak or the maximum inspiratory pressures that the VDR generates at the alveolus and certainly at the terminal bronchioles or wherever it is that this air leak is coming from. I mean, if it's bad enough, maybe the patient just needs to be on ECMO and then you put the patient on full lung rest. But
yeah.
It's like the ultimate non-conventional mode of ventilation.
Right. And then you have to watch for adverse hemodynamic consequences. So while it's less likely to develop adverse hemodynamic consequences than if you put them on the oscillator, it's still something that can happen with steady worsening of overdistension. And the first thing we watch for is tachycardia. So if you have a patient whose heart rate's been 120 for the past 6 hours, and now all of a sudden it's like 140, and it just seems to keep rising, and nothing, and you don't think it's because they just need a fluid bolus because they are dehydrated or something, then that's something to get a chest x-ray for sooner rather than later to assess. Mm-hmm. Those are the key things. The other thing then is when you're on the VDR and everything's been fine and all of a sudden everything's not fine, then the first three things we do is suction, 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 the ET tube. Because more than likely, the acute thing that changed is that something got plugged. So you got to clear that mucus plug out.
No. Is the fourth thing an x-ray?
And then the fourth thing is an x-ray.
Yeah. Well, you really can't replace these clinical pearls. This is really fantastic. As we sort of wind down, any tips on weaning the VDR?
Sure. So same as with any mode of invasive ventilation, pressure is the king of weaning. So as soon as the patient is demonstrating any ability to decrease the amount of CO2 clearance you're trying to achieve, take the AIP down. Even before you go back to a 1-to-1 IDE, if, for instance, you had gone to an inverse IDE ratio. Because it's the AIP. Because what goes along with the AIP is then this maximum inspiratory pressure. If you lower the AIP, the maximum inspiratory pressure will also come down. And that's the key. The AEP wean the same you would any other patient's PEEP and their overall mean airway pressure. If the patient's not paralyzed and they're breathing fine and they still have a lot of secretion issues, but their gas exchange continues to improve. While I've never done this, theoretically, you could just extubate somebody from the VDR.
Mm-hmm. Mm-hmm.
And that extubated VDR setting would probably just be really long respiratory cycle, so a really low convective rate, so a rate of 10, which then gives a respiratory cycle length of 6 seconds, an I time of 4 to 5 seconds, an E time of 1 second to 2 seconds, an AIP in the low teens, high single digits, an AEP of 5, FiO2 of 40%, and they're comfortable breathing on that, then that would be an extubatable setting if you were to extubate somebody from the VDR. Which, again, I've never done, but theoretically you could.
Yeah, the respiratory therapists probably want to stop dealing with it, but at a certain point. I realized we didn't ask, but proning on the VDR, are you doing this?
Yeah, so there isn't any reason why you can't prone somebody who's on the VDR. There's some geometry you got to sort out. So the phasotron needs to be in a certain orientation relative to gravity. So there's always a bunch of towels that are propping it up. It's also kind of heavy, so you need to be cautious that it's not yanking on your endotracheal tube. We have never put a patient on the VDR as the first thing while they're prone. So to put them on the VDR, we'll put them supine. Once we're happy with those settings, then we'll flip them prone. And that combination of VDR and prone positioning has really, really achieved quite satisfying amounts of mucus clearance.
I guess neuromuscular blockade, do you see it any differently on VDR?
So one of the advantages of the VDR is that you don't have to keep the patient paralyzed. And in this CHOP paper, they saw no difference before and after VDR use with respect to the percentage of patients who were requiring neuromuscular blockade. The older patients you can talk through. So we have had former lung transplant patients who are now developing chronic lung allograft dysfunction, who are being assessed for repeat lung transplant, who've been supported on the VDR, and they're minimally sedated and they're breathing on their own. They're totally content. We have had oncology patients who have some opportunistic lung infection that generates a lot of secretions, who are really, really anxious, and they haven't tolerated spontaneous breathing on the VDR. Mm-hmm. We've had younger kids who seem totally fine breathing spontaneously on the VDR, and some kids who don't. It's different, for sure. I've had the opportunity to have through a mask IPV therapy, and it takes a little bit of thought to breathe.
Yeah. Mm-hmm, mm-hmm. Yeah.
When you're in the middle of one of those treatments, but it's doable. So it's like if they can get away without paralysis, then great. We'll try that.
Yeah. Oh. Maybe if we're walking through your ICU and respiratory season in the wintertime, are we likely to see one patient at least on the VDR, or is it a little less frequent than that?
So it's interesting that you asked this because it's gone in phases. When we first introduced it, we own 4 VDRs. We were needing to rent another 2 to 3.
Wow. That's legit.
And then in the past 2 years or so, the use of it has really tapered off. Whether that's a good thing or a bad thing, I don't know that I necessarily have an opinion about that. I must say that even before the VDR, we introduced it, we weren't using the oscillator very much. So I'm curious to understand whether or not your institutions still use oscillatory ventilation frequently or not.
Infrequently.
Yeah.
Yeah.
More frequently, DC's an APRV house, but Cohen Children's will do both oscillator and VDR pretty frequently.
Got it. And then after we introduced the VDR, then our oscillator use really tapered off.
Yeah.
And now mostly we're just manipulating conventional settings.
Wow. You see yourselves moving towards just, we're going to get through this with a conventional event, stretch out the eye time, things like that. Wow. Well, a lot to think about here. Dr. John Lin, this has been an incredible gift, especially for me, but really for our listeners as well. What do you have to close out with? What should the PedsCrit listeners keep in mind about percussive ventilation?
So unfortunately, as of October 31st of this year, the company that makes the VDR isn't going to make it anymore. So they are pulling out of the US market. They'll continue to service and support active VDR devices for up to 10 years. And then they have this phrase in their announcement, as long as components are available and as long as the cost of repair is reasonable.
Oh,
So,
no.
whatever that means. And then they'll continue to provide the disposable circuits. So if your institution doesn't already have the VDR, I don't think it's worth the effort trying to get it. If your institution already has the VDR as part of its armamentarium, it's worthwhile to start to think of what you're going to do when the parts start breaking and the company refuses to fix it.
Yeah. Well, gosh, I mean, as Alice said, it's been a real pleasure having you here, and we're so excited to share this with listeners.
My pleasure. Thanks so much for inviting me. It's been a great time. I've enjoyed it.
And thank you for listening to this episode of PedsCrit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of PedsCrit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of PedsCrit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.